So hello and welcome to the second in the series of the BSAVA Science webinars, taking a closer look at some of the papers published in the Journal of Small Animal Practice. I'm Luisa Dormer, Scientific Editor at the BSAVA, and today I'm joined by Nick Jeffery, Alice Legal and Karen Humm to discuss the paper Xenotransfusion of Canine Blood to Cats, a review of 49 cases and their outcome. Nick Jeffery is a professor at Texas A&M University in the USA and is currently the Editor-in-Chief of the Journal of Small Animal Practice. Alice Legal is a resident in the Emergency and Critical Care team at the Queen Mother Hospital for Animals, the small animal referral hospital at the Royal Veterinary College in the UK. Karen Humm is an Associate Professor in Transfusion Medicine and Emergency and Critical Care and Director of the Transfusion Medicine Service at the Queen Mother Hospital for Animals. Welcome to all of you and thank you for taking the time to discuss this paper today.
Thank you, Luisa.
Thanks.
As a starting point, Alice and Karen, I hoped that you would be willing to briefly outline your research, please.
Hi, thank you. As a large referral centre in the UK, we see a large number of anemic cats that come to see us, either referred or as a primary care, and some of them need blood transfusions for various reasons. So whether it's hemorrhage, pre or post surgery, or IMHAs, neoplasias, and sourcing appropriate donors can be difficult, especially with cat donors, either because we don't have the right blood type or because it is just in general difficult to find cat donors. So sometimes we have to use xenotransfusions for some of our cases, and as a result we are using a standardized protocol to ensure patient safety and appropriate use of xenotransfusions. So we thought with this paper that we could describe the outcome of the cases that we've seen between 2016 and 2018 who received a xenotransfusion, so all the ones that presented and got a xenotransfusion. So that's the 49 cases and the outcome of these cases. So amongst all these cats that received the blood transfusion as a xenotransfusion, 12% of them had a febrile non-hemolytic transfusion reaction, and we didn't have any other acute reactions during the transfusion itself, which maybe we were monitoring for and were noting if they were happening. And we know that these cats were obviously critical and they were deemed at risk of mortality within the first 6 hours of presentation to receive a xenotransfusion in the first place, and 20% of the cats died or were put to sleep during within the 24 hours post xenotransfusion. So for the ones that were put to sleep, most of the time it was because we had test results that were pending that didn't give the cat a good prognosis and they were put to sleep at the time. These cats were then monitored for hemolytic reactions at least once a day, so that would be either for hemolyzed serum or hemoglobinuria or icterus. And we had 64% of our cats who had delayed hemolytic reactions, and we saw them as early as 24 hours post xenotransfusion. And the cats that were then discharged, we attempted to get follow-up on them. So we managed to get in touch with 15 owners of cats who were discharged, and we were assessing whether or not they remembered that the cat had a xenotransfusion, because they were given the information as the cat was getting the xenotransfusion and also in a written and oral format. And we were trying to figure out if they remembered that their cat could not get a second one and how the cat was doing in general. All of them remembered that their cat had received a xenotransfusion. Only 9 of them out of the 15 remembered that they could not get a second one, but we had 8 cats that were completely recovered from their primary disease and that the owners were completely happy with.
Yeah, I think it's probably worth adding as well, Alice. I think we did collaborate with Edinburgh on this, so some of the cases were from Edinburgh University as well. And so, yeah, we worked together as a team to do that. And as Alice said, our transfusion reaction rate, we had the 2 sorts that we really noticed, the febrile ones, the acute non-hemolytic febrile ones. And actually they were at a similar rate to any feline transfusions, given what the literature reports at the moment. And then, as you say, that massive thing, Alice, of the delayed hemolytic transfusion reactions, which obviously is very different to allotransfusion.
Great, thank you. So actually just picking up on your last point then, just to ensure that everybody's on the same page, could you just refresh our memories of what xenotransfusion is and how that differs to allotransfusion, please?
So sorry, Alice, I'll go. We'll take it in turns. Alice and I will take it in turns, and then that'll be easy. A xenotransfusion is the transfusion of blood from one species to an unrelated species, whereas an allotransfusion is transfusion of a blood product from one species to the same species. And an autotransfusion, although you didn't ask, but another commonly used term, is when you transfuse an individual's blood back to itself. So you often do that in veterinary profession as well. Say if there's a hemoabdomen, people often do an autotransfusion, or it's not uncommon. So yeah, those are the 3 different types.
Great, thank you very much. And so when then you're trying to decide whether to give a blood transfusion to a cat, what rules do you follow or do you implement?
So I'll go for this one. Basically, I think we have like rules that are a bit like dependent to obviously clinicians, but we in general try to have like a committed owner, because even like when it comes to costs or emotions as well, it's going to be sometimes very difficult, really long, and they might be prepared to have like not just the one transfusion but actually many, and the cat might be in hospital for a while. We usually also have a look at the underlying disease, whether it's a treatable disease, whether it's something that we are able to have a good outcome with, or at least on the first basis that we're able to treat. We don't usually say, oh, if you've got this PCV, then we know that we're going to have to transfuse. But I think in general, as a rule, we know that if a cat presents with a PCV that is less than 12%, we will end up transfusing the animal at some point. We always like have a look at the physical examination findings in parallel to that. So is the cat cardiovascularly stable? Is it tachycardic? Is it pale? Does it have like hyperdynamic pulses? And neurologically, is it reluctant to move, like very quiet? And then we like corroborate that with the PCV that we have. We obviously always start with fluid resuscitation, and especially if the patient is hypovolemic, and if it's still, the animal's still unstable after that, then we are likely to transfuse. And then also if we expect the disease to progress, so typically with the IMHA patients, even if they come with a PCV of 15 and initially look quite stable, we know that it's likely to progress and that we are going to need a transfusion. So that would be one of the cases that we would also transfuse. Animals that are going to have a general anesthesia, so we know that there'll be like maybe some blood losses, and that will also have a drop in PCV. Or if we have things like pelvic fractures, fracture repairs, where we know that the PCV they come with, and then they're going to have like a fracture repair, and then they're going to go to theatre, they're going to have further blood losses. So these ones we're likely to transfuse as well, even prior to going to theatre.
Could I just step in there to ask a couple of questions? I've gone off piste again, I'm afraid, but you mentioned that, but there's quite a high complication rate from transfusion, and you know, you're mentioning transfusing cats with IMHA, but you know, they can get stable at relatively low PCVs and then recover. How do you balance out those risks about when to transfuse? So, I mean, there's no solid data on this, I don't think, is there?
No, I don't think there is, and I think that's a really good point, Nick. And I think when we transfuse, it's so important for us to think about the risks when we transfuse, because transfusion reactions are not at all uncommon. Like I said, that febrile non-hemolytic transfusion rate of about 10%, it's pretty high, you know. And what other drugs do we give that have a complication rate that high? You know, it's pretty impressive. So we have to be cautious, and I feel like we also have to be cautious as well on behalf of the donors, because the donors have to go through essentially a kind of unnecessary procedure to obtain that product. So both from the donor's point of view, we have to be really cautious about whether we need to give a transfusion, and then also from the risk of transfusion reactions with the recipient, definitely we need to be cautious as well. And so it is, as Alice said, just those really multiple little points, and it's one of those ones that comes down to the art of veterinary medicine. I think there are no absolute hard and fast rules of at this fixed PCV you transfuse. It's taking the whole picture and trying to make your best clinical judgment, and that may be slightly different to someone else's. Having said that, there are some obvious ones where we've got a very unstable patient with a PCV of 6%, it's probably going to die if we don't give it blood, if it's bleeding out in front of us.
I think for the IMHA ones as well, we have like stages where we're more tolerant. So if they're more cardiovascularly stable with a PCV of 10, but we know that we've gone through the investigations and we're happy with our diagnosis with AMHA, then we would like be a bit more reluctant to transfuse because of these reactions. But if we know that we're at the early stages where they're going to need investigations, then we're maybe a bit more proactive and taking a bit more risks and transfusing them, because we know that they're likely to go through a bit of more things in the near future, and then we probably take a step back after that.
Yeah, if they're going to need sedation or something, definitely, that we know is going to struggle, sort of challenge their cardiovascular system more, definitely.
Yeah, I just following up a little bit, I noticed in your paper you'd said that there was an indication that they were likely to die within 6 hours was one of the inclusion criteria. And, you know, again, I understand that you can't necessarily you know, be very definite about that. But have you got any examples of cases that where you made that decision?
That they were likely to die. I think probably the really clear-cut ones, as you say, Nick, it's really hard to definitively say this animal is going to die. And the reason we said that within 6 hours was to really allow us to say, well, do you know what, that's the length of time in which we've really struggled to get hold of a donor, get them in, bleed them, and get a feline blood product. That was really where the 6 hours came from.
Okay.
If people are wondering. But I think probably the really clear-cut ones with those are actually, the obvious ones are surgical issues when there's a bleed, an intraoperative bleed. And probably one of our really common ones actually was hepatic surgery. So say like a shunt or maybe a PDA. If that sort of cat starts to bleed, it's really hard to stop them. So they're the ones who can often need, and actually when sometimes a xeno become particularly useful, because we can give a much larger volume. A unit of feline blood is obviously quite small, whereas you can give a lot more canine blood.
Yeah, well, sorry about this, Louisa. I've just got a bit between my teeth a bit, but there could be a case for making, and I know some people do make this case actually, that perhaps you'd be better off to just give dog blood to cats, because the complication rate that you show is relatively low. You can give a lot of blood and you won't give them, you're less likely to infect them with well, certainly with the feline virus anyway.
Yeah, I mean, it could be argued that way. I mean, I think given the other complications and what as Alice mentioned at the beginning, we did follow up with owners. The risk, therefore, particularly in a young animal, would be if they're rehomed, if an owner forgets that they've had a xeno. And I think that was our big worry, and that was why we put that as part of the project, wasn't it, Alice? To try and see whether owners did recall. And it was interesting to me that they definitely remember the fun fact about them having had dog blood, but not necessarily the not so fun fact that a second transfusion really needed to be avoided.
So going back to talking about PCV, how much of an increase in PCV do you expect to see immediately after a transfusion?
Go on, Alice.
So we then, there are like several equations that I think you can use, but obviously for a peace of mind, and because I think it was just easier for everyone to remember this, we kind of go for 1% of increase in PCV goes with 1 ml per kilo of packed red blood cells. So if you do like quick maths, if you've got a cat that comes in with a PCV of 10% and you aim for a PCV of 20%, so a 10% increase, your cat's 5 kilos, then like, yeah, 10 times 5, 50 mils of packed red blood cells would do it. I think sometimes we've had the question recently in one of our clinicians asking, they had the feeling that maybe with xenotransfusions we ended up having maybe a higher PCV after transfusion for that equation. But if we look at the data in the project in our paper, then it actually matches. We have like a median PCV before transfusion of 10%, and then the median volume transfused was 14 mils, and then we ended up with a PCV at the end of like 25. So we're quite close to actually that and to getting those results if we look at 12 hours post, not immediately after the transfusion.
Yeah, I noticed actually it's one of the things that isn't very clear in the paper that we should have picked up in review probably, but you didn't mention the change in PCV for each animal, and you can sort of work it backwards from the data that you provide, but are you able to comment on that anymore?
As in, other than how much it changed per, so as Alice said, it was about 1 ml per kilo, but that was at the 12-hour point, so it relied on the patients having made it to 12 hours, which some of them didn't because of the seriousness of their disease processes.
So looking
did
at
it vary much, you're asking?
Yeah, looking at your data, I think the lowest one you transfused was 6, and the lowest one that was at 12 hours was 10. But you can't necessarily assume that it was the same animal. But I'm just trying to work out, you know, roughly how much change in PCV you were getting from these.
So it really varied on the underlying cause. So for the ones that, and again, if the easy example is the surgery, if they were bleeding, it was very hard to, we had a starting point PCV, but actually whether that was actually a true PCV, had the animal been volume resuscitated, probably not. And so there's a complication there. And as always with these studies, you know, you want it to be really nice and clean, but the data is actually a little bit dirty. So I think taking the averages that Alice talks about is probably fair. But if you look too much at the nitty-gritty of individual cases, it becomes a little more confusing, particularly those surgery ones.
Yeah, actually, I seem to remember having that conversation during the review process. Now you've mentioned that. Yeah, but yeah, I can see your point. Yeah. Oh, it's down to me again. Some more questions. You only did some of the tests, like cross-matching, on some of the cases. Why did that happen?
Do you want to go, Karen?
Why were only some of them tested?
I'm happy to go.
Go on, then yeah, I can say. So basically, it depended on whether the patients, we had time really, and we could get enough blood. So we ideally wanted to do cross matches on them all, but some of the patients were very, very unstable, and so we either were scared of taking that much blood, but more commonly we actually couldn't get, because to do a cross match you want a decent volume of blood, and we couldn't actually obtain that amount, and sometimes again in the rush in these again clinical study, in the rush of dealing with these very unstable patients, clinicians sometimes forgot, frankly, to get hold of the blood. So ideally we would have had more cross matches, but interesting, the results we did get a decent number with cross matches, and we didn't see, interestingly, any kind of relationship between longevity of the blood cells and or the transfused cells, as far as we could tell, and the cross match results, and that's actually been shown in another study as well. It was quite a small study, only 2 cats, but they didn't see any kind of relationship. So our cross-match incompatibility is common between feline and canine blood, but I guess what was interesting, my take home from this study was don't worry about that too much. Like, you know, it's going to probably get destroyed. It's not a long-term option, but is it, like, if it's cross-match incompatible, you're going to see dramatic, life-threatening acute transfusion reaction? This didn't seem to suggest that.
Yeah, quite a lot of your animals got a second transfusion with cat blood, didn't they? I forget exactly the proportion, but it was quite high, wasn't it?
Yeah, and that was also the aim of like showing this, is that like most of them will then need to have a second one, also because of the underlying disease process. And I think typically the IMHA ones will definitely need another one. The ones that didn't need them, we've got one of the like long-term survivors, and was like one that bled during no varial hysterectomy, and then typically regenerated, very young animal, regenerated really quickly, like got out of the hospital with just that one xeno, and then was doing really well. But I think the ones that have like more complicated underlying disease will then hemolyze this blood and will need a second transfusion.
Yeah, yeah. So how do your results compare with other studies? You know, I guess Xenotransfusion or with cat transfusion. How do you think your results work out?
I think. Sorry, go on, Alice. You go, Alice.
So I think globally we were really looking for that, like the days after transfusion where hemolysis would happen, and that was like one of our main concern and what we were really looking for. We know that before it's been reported to have reactions between 4 to 6 days and have hemolysis 4 to 6 days after the xenotransfusion, and possibly because we were also looking for it, and it was kind of mandatory to have a check every at least once per day of like looking for hemolyzed serum, hemoglobinuria or icterus, or anything like that, and the clinicians in charge of those cases were really aware of it. Then possibly we saw it earlier because of that, but we saw it as early as 24 hours post xenotransfusion. So once again, one of our major take-home messages was like, if you do it, then get ready for hemolytic reaction, and it could be very early and as early as 1 day after you've done the xenotransfusion. So that process of like getting a feline blood donor in and finding appropriate cat blood then could be quite quick. And then in terms of long-term follow-up, we tried that to get, like, because we had more cases to get the long-term follow-up had been described in previous studies that cats that had received a xenotransfusion were discharged from hospitals, but we didn't know how they would do then on the longer term. So it was quite nice to have that follow-up after that and know that they were doing well and didn't have any consequences of it, at least on the longer term.
Yeah. Yeah, you also wanted to develop a protocol and assess the adherence to this protocol. Did that work okay?
Yeah, it did actually. The protocol was well received and followed, which was quite nice. And the reason we wanted to do it, one was obviously for practicalities of our own hospital. We wanted something that we felt, because before we'd actually published this, there was very little about clinical. There was odd case reports, but not very much out there of clinical case series. And so we wanted to look at it in a bit more detail. And because of that, we wanted to be very careful about the cases that were being selected to make sure that that xenotransfusion was only used if that was the only option. But actually, when we were talking about designing the study, we also thought that perhaps it would help people in practice to have a protocol to follow. So yeah, just that pragmatic, do we really think it's likely to die? And one of the things that was in our protocol was discussed with a member of the transfusion medicine service. Now, obviously, the vast majority of practices are not going to have a transfusion medicine service, but I do think that idea of just bouncing the idea off another colleague might be something that should be considered before performing a xenotransfusion if you have the opportunity, just because they may have a slightly different view on it, or might have come up with a different a possibility for you. So one of the things that sometimes prevented us from doing a like an animal might have been suggested as having a xenotransfusion, and then we might have said, well, actually, can you do an autotransfusion? And that was chosen as an option instead. So just that brainstorming, better to share the ideas and see if there's another solution. Because although we've written about this and we do think it's potentially life-saving, I still don't think it's best practice or gold standard, if that makes sense.
Yeah, so actually I was just thinking I'll have to ask you the $20 million question. Do you think people in primary care practice should be doing this?
I think they are. I think they are, and they have been. And I think the literature has been a bit backwards in catching up with it. And in certain countries, it's been much more commonplace than others. Certain parts of Europe, and I think Australasia. And so anecdotally, we knew it was happening, but I think maybe referral hospitals are a little more prissy about it. And we had oxyglobin as an option, and then that went away. And if you didn't have the blood banking option, then it was actually something that then maybe people who hadn't had to think about it before had to consider. And so do I think people should do it in practice? Yes, if they think very carefully and they don't have any other options. Personally, I don't know if you have anything to add to that, Alice, or if you agree.
Yeah, I think I agree. And ironically, I think I presented this paper in France, because full disclosure, I am French. And when I presented it there at a conference, just before the conference, the person who was presenting said, oh, like, we're going to talk about xenotransfusion, which is a bit of a like shameful practice. And she asked before I had the talk, like, has anyone ever done this? Like one person like shamefully raised her hand, and then I did the chat. I explained that obviously I had done this study at the RBC in collaboration with Edinburgh, and then so after the talk she asked again, has anyone then done a xenotransfusion in practice? Literally 3/4 of the room raised their hands and felt much more comfortable saying that once they had heard that, okay, they do it somewhere else, maybe it's okay. And then actually the person who was presenting herself actually raised her hand as well, and she was like, yes, so did I. So I think people are maybe a bit ashamed of saying they do it, but then if it can save lives, why not? Sorry, my cat is taking part of this.
So you'd see the key thing as being setting up a decision tree, I guess, is the thing about, you know, whether that is the thing that you end up doing. I guess you want a very quick decision tree that you can complete within a few minutes, but that's sort of like the way that you're talking about this, really, isn't it? I think.
Yeah, being carefully making a pragmatic decision is probably how I'd put it.
Great. So for one final question, and I'm just touching on picking up on the research point of view, really. Obviously, this research was the first to examine the long-term outcome of a large number of clinical feline patients receiving canine blood. But what further work do you think needs to be done in the field?
So I think in terms of what we were looking at, obviously we wanted to have a look at the long-term outcome, but we had a very high mortality rate. I think by definition our patients were quite critical, and so we have like those 20% of patients that died within the first 24 hours. So even if we didn't see any acute reactions during the xenotransfusion, we can't exclude that they would happen, and that we have missed some of them as well because our cats were so ill otherwise. So any further case reports, any case series would probably be helpful and help us find out if there's some things that we didn't see. And then we've started like opening with that and looking at maybe effects of like hemolysis on kidneys and on whether or not we see acute kidney injury in our patients. But once again, that part of the data then wasn't mandatory in our protocol, so wasn't collected as the rest of the data was collected, and so we don't have enough data there to actually say something. So looking into like markers of AKI in there would be really helpful, and seeing if there's any signs of effect of kidneys being affected by the hemolysis. And then it would be nice to know whether or not, like every report of a second xenotransfusion seems to be fatal, but it'd be nice to know if we could like have titration of the antibodies and knowing how long they last, and whether or not in the longer future it'd be possible to repeat a xenotransfusion. Obviously that would be for animals that do well and then unfortunately need a xenotransfusion much later in their life. It'd be unfortunate, but it would be good to know how long these last.
Do you think there's any room for doing a randomized trial between cat and canine blood?
I think it'd be really hard to get past an ethics board.
Yeah. Really? Yeah.
Yeah, probably. And I think, you know, it's choosing the right cases for it. So it's because of that second transfusion risk that all the big experimental studies, or the bigger, you know, ones back from in the earlier or middle part of the last century, when they did some not so nice experiments when they took, you know, healthy animals and gave them a first and then a second xenotransfusion, because pretty much all of the ones that had a second transfusion died, that to have that as a possible risk is a big thing.
Yeah, I think the thing is that there are reasons that you might prefer canine blood though, I think, aren't there? Like infection risk?
Yeah, the infection risk, as we talked about before, the volume you can give, the readiness of availability, the lack of worrying about blood type. You could make quite a few arguments, definitely. So yeah, in some cases it is probably going to be well, we think in these cases that we presented it was the best option.
Yeah.
Great. Well, thank you so much for you all for giving up your time today to discuss xenotransfusion, and thank you for listening. As a reminder, the full version of this paper can be found in the March 2020 issue of the Journal of Small Animal Practice. A link can be found in the comments below the recording. Join us next time when we will be discussing the paper Long-Term Biological Variability and Generation of a New Reference Interval for Plasma N-Terminal Pro-B Type Natriuretic Peptide in Labrador Retrievers.